guidelines are for really sick children?
The trajectory of a child, how they change over time, I think is far more informative than any set of observations.
You've got one choice and it's adrenaline.
The evidence is clear that early antibiotics are better than late antibiotics.
But if they're sick, use it quick. Hello and welcome to our Paediatric Sepsis podcast series, brought to you by the Royal College of Paediatrics and Child Health and the team from the Great North Children's Hospital, with guest speakers from all over the country. My name is Emma Lim, and I'm a general paediatric consultant at the Great North Children's Hospital. And hello from Johnny at our mixed desk. He's come to help us from MediSense, and we want to bring you up to date with real discussion and debate from experts all over the country to help you think about how you treat sepsis and save lives. We wanted to explore the new and first ever sepsis guidelines for children and young people. Who better to take us through this than Professor Mark Peters, consultant at Great Ormond Street Hospital, PICU, that's Paediatric Intensive Care Unit, and researcher at University College London and the Institute of Child Health, and more importantly, co-author of the guidelines. So Mark, first of all, thank you very much for having me. We are actually recording in Alnmouth, the most beautiful part of the Northumberland coast. So for once, you've come up north to see me.
Yeah.
And when I looked at your guidelines, I just felt incredible awe that you had managed to get so many people in one room and made them agree on anything.
They were very rarely in the room. It was mostly done on the most colossal teleconferences, which we've all got used to now. But at the time, it was a challenge to get 30 people regularly on a phone call to discuss their preferences for sepsis care.
Well, I wish you came and lived in my house and got 5 people to discuss and agree on anything. This is about the publication of the Surviving Sepsis Campaign International Guidelines for the Management of Septic Shock and Sepsis-Associated Organ Dysfunction in Children. Right, so this huge piece of work. Let's start by trying to recap. First of all, at the very beginning, can you define sepsis according to your guidelines? And we all know this is the bugbear of everyone.
Yeah, so you started with the most difficult question. Sepsis definition for these guidelines was chosen to be when something's going wrong with a child's body in the context of infection. So we are trying to avoid guidance on trivial infection, but only when it's progressing to the point that it becomes life-threatening. We can go into the reasons for selecting that as a definition, but it gets quite complicated, and it reflects the fact that the paediatric definition is old and really not fit for clinical purpose. It's a research tool, and also that there's an adult definition that's relatively new in the last few years that has focused on the life-threatening nature of infection. And so we were trying to sit between the history of paediatric sepsis definitions and the current adult practice.
So in summary, we're saying these guidelines are for really sick children.
Yep.
Defining really sick children is not straightforward.
Exactly.
Understanding how to recognize sick children is not straightforward.
I agree, but I think one of the points I would make, it's not a question just of the child's state, but of how that state is changing. The trajectory of a child, how they change over time, I think is far more informative than any set of observations.
And I think that's really important, because the person who will know best what that child's trajectory is the parent.
Yes.
There we go. We've entirely agreed on one thing to start, so that's great. Okay, so we've discussed what is sepsis. And then the next thing that is really important are what are guidelines? So what is a guideline? How should you use a guideline?
So a guideline is a collation of evidence through a standardized methodology to provide guidance to clinicians about how they should consider delivering their care. It's worth saying that when guidelines are prepared for children, they frequently have less of an evidence base to start from than do our adult colleagues. And hence, there's often more opinion contained in our guidance. There's often more descriptions of what we believe as a group of relevant clinicians is best practice. But it's a systematic collation of evidence with a standard methodology.
Excellent. So I think one of the things to remember is a guideline is a suggestion. You are the clinician on the ground, and you are the only person who can make a decision because you have the child in front of you. And this is a tool that should be there to help and guide you, but it is your decision in the end.
For sure. And for each of the 70-odd recommendations we make, we are talking about the majority of children in this scenario, what the evidence tells us. It doesn't tell you, that doesn't necessarily hold true for every child. There may be certain circumstances that modify that baseline risk for the individual child. So this is an average recommendation for the average child in this situation. And in some places in the guideline, we make that clear that the recommendations we are making are sensitive, for example, to the healthcare setting in which you're delivering care.
And just to give everybody some idea how important these guidelines are. So there were 30 people who worked over a couple of years.
It actually took 3.5 years to produce the guidelines.
And how many papers did you look at?
We ended up with references of nearly 500 papers.
You have a couple of choices. You could choose to spend 3.5 years reviewing the 500 papers yourself. You could read the guideline, or you can listen to our podcast and Mark will tell you and summarize what are the most important points.
I think the other point we'd make about guidelines is that it isn't a single person's interpretation of the literature. It is a standardized aggregation of the evidence through a whole group. And there were many discussions about the wording and the emphasis of the recommendations we gave.
If you think about it, these guidelines is like having all the experts in your pocket telling you what the best thing to do is. So we've talked about how you developed them. We've talked about what guidelines are, and we've talked about what sepsis is. And we haven't even got to the beginning about what to do yet. Good start. So, first off, sepsis, early identification and the role of screening. What do the guidelines say?
Our first recommendation was around children presenting as acutely unwell, and the Guidelines Committee suggested implementing a systematic screening program to enable timely recognition of shock and other organ failure with sepsis. Turns out there isn't a huge amount of evidence for this, but everything that there is does point in the same direction as this being a good intervention.
This is about being systematic and careful and rational. This is about having a system that records children's observations and how unwell they are in a timely manner and a consistent manner all the time. So if you have a protocol, this means you're not just picking out some patients, you're looking at all your patients and you're screening them, and then a person will come along and make a decision once they've seen that children.
Yes, and we don't make detailed recommendations about what the detail of that system should be, only that you should have a system that's relevant to your local environment. There's a number of elements to it. There's how far from normal physiology are they right now? There's an issue about which way is that heading, and there's a senior review to try and integrate that information into making a decision. And the one thing I would say, and this is not from the guidelines, but it's a personal view, is that you should be very wary of anybody saying this is not sepsis in that screening process, unless they have a really robust alternative diagnosis.
It's really important to think, really what you have to do is rule out sepsis. You have to look at every child and see if it is reasonable to rule out sepsis. Right, next one-liner, lactate. Is the jury in or out?
So if you can estimate lactate at the bedside, it does add prognostic information.
Well, that's very quick. This is about saying, if you have a sick child and you can take a blood gas which has a lactate on it, that's useful. And remember, a trend is also useful. Is it going up or is it going down? But it's not the be-all or end-all.
Yes, I mean, without getting overly complicated, lactate is sensitive, but it's not specific. So
we've covered screening, we've covered lactate. See if we can do antibiotics in 3 sentences.
Oh, is that the question? Okay. Antibiotics, good thing. So our recommendations include starting with broad spectrum antibiotics that cover the relevant pathogens and narrowing that antibiotic spectrum as soon as you have further diagnostic information.
That's excellent. So that feeds straight into the start smart, then focus.
Indeed.
That's a national recommendation. And remember to involve your microbiologist or infectious disease specialist when you're making these choices, and to review this on a daily basis. So we're totally in agreement so far, so this is good. But what about the timing issue? Because I think people have really struggled with this antibiotics within 1 hour, and I think you've come up with a neat solution.
So there was a lot of discussion about the timing of antibiotics, and remember, this guideline is informed by the evidence, and the evidence is clear that early antibiotics are better than late antibiotics. The focus on delivering appropriate antibiotics within 1 hour in our guideline is limited to patients who are in septic shock, and within 3 hours of recognition in those children who are not shocked but had other forms of sepsis-associated organ dysfunction.
So this is really important. I think what has helped us with these guidelines is, if you're thinking about all the children who have a fever but who are not shocked, and you are yet to find a diagnosis and you suspect infection, you've got the time to do some tests first, to get a bit more information, and then decide to treat them. Or if you have another diagnosis, which is not sepsis, not treat them or observe them or choose another management.
Yes, and I think the focus is on rapid correction of shock being in a different level of priority than other forms of infection. For example, a child needing some supplemental oxygen in the context of infection. That's not the same as low blood pressure, poor perfusion, which is absolutely a medical emergency.
Yeah, that's the nub of it. So if you're shocked, it's a medical emergency, get antibiotics in. For all those febrile children who look unwell, you have time to do other things. And we also have the huge issues of my antibiotic stewardship and trying not to use antibiotics in every single situation. But if they're sick, use it quick.
That's very good. And I think this is a complex balance. The appropriate and prompt use of antibiotics it's just a challenge for everyone to not be using it too broadly. And we're hoping that molecular diagnostics and other things that are coming down the track may improve on this, but with current information, systematic screening, starting broad antibiotics when you are worried about a child and rapidly if they're shocked is probably the best we can do.
I'm glad to see that we've kind of whizzed through the straightforward things to get to fluid therapy. It's not one rule for all. So explain, because if everything else was difficult before, this one is definitely more tricky to unpick and to use in real life practice.
Yes, we were really keen that our recommendations about fluid therapy captured some of the subtlety of the literature and And there's a tension between the data in high resource settings, which is largely supportive of fluid expansion in shock, and of course the famous FEAST study, which showed clear harm from fluid expansion in East Africa. And so the way we try and reconcile this in our guidance is to make the recommendations specific to the healthcare setting in which you're working. And that's novel. That hasn't existed in previous hemodynamic support guidance. But essentially we're saying if a child is shocked, they should receive fluid resuscitation, isotonic fluid resuscitation. But that should be in the context of rapid and continuous reassessment for whether there is still residual shock or whether there are signs of fluid overload.
Great. And I think we talked about this in our previous podcast. So it's really important that you do give fluid boluses if you think it's necessary, but you might give 10 mils per kilo and then you would reassess. And it's really important to look for signs of fluid overload and then give the next bolus if you think it's necessary. So that constant reassessment of their fluid state is really, really important.
Yes, I hope we've captured that in the graphics that accompany the guideline that make a point about a continuous reassessment.
Oh, I love a flow diagram.
Yeah. Yes, I think there's a slight change in tone of the guidance from previous fluid recommendations, in that there's more of a focus on an early assessment of myocardial function. So I think what we're trying to represent is a sort of greater awareness of the potential harm of overly aggressive fluid resuscitation. And part of the way you understand that risk is knowing what the myocardial function looks like. And that's clearly something that can only really be done by a regional service, or if you're lucky enough to have expert echocardiography locally.
So remember, you're part of a team and you need lots of other people to give you a hand in this case. Don't be scared to call for help.
In a healthcare system with access to intensive care, if you have evidence of shock, we are recommending fluid administration, 10 to 20 mils per kilo of isotonic fluid. And then we're recommending repeat hemodynamic assessment. We just raise the profile of assessing myocardial function earlier into the algorithm, as I think we've understood quite how varied children's hemodynamic responses to sepsis can be. That's not asking you to make a diagnosis of cold shock or warm shock at the bedside, because that's notoriously unreliable. But it is saying this needs to be considered in the process. Doesn't mean you shouldn't start fluid resuscitation. It means you just be aware that the risk and benefit of fluid resuscitation may change quite rapidly.
Brilliant. I think I understand it now.
You may be able to pick some bits out of that. That makes sense, I think.
No, I think that one was good. So, in summary, still give fluid boluses. Give them cautiously. Reassess between boluses. If you can, get people to help you estimate cardiac output and fluid overload. When you've got to about 40 mils per kilo, so you would have given at least 2, if not 3 boluses of fluid, what do you need to think about next?
If shock hasn't resolved after 40 to 60 mils per kilo, we make a recommendation to consider using an adrenaline infusion at that point. If there is also evidence or a history that suggests myocardial dysfunction, you may use it earlier.
So I think this is really interesting. We talked about this before as well, adrenaline. You've got one choice and it's adrenaline. And people have been quite scared of using adrenaline. Do you feel that's kind of changed, or do you think people are becoming more accepting of using it early?
So I think the PICU community has pretty much changed to using adrenaline as first line. Septic shock, vasoactive drug. I think increasingly we're seeing that in the local accident emergency departments. Most of the reticence about adrenaline infusion is a fear of tissue damage, skin necrosis on a peripheral or intraosseous needle, we have to say both my experience and what evidence there is in the literature say those are very rare events. And actually, I would argue that risk is negligible compared to the risk of not controlling shock in this situation.
I think that I agree with you. It's better to be alive and have a small necrotic patch on the back of your hand. As you say, do you know, I don't think I can remember ever having problems with peripheral adrenaline.
If you're at all concerned about your peripheral line in the situation, you should be using an intraosseous.
Yeah, totally. So all the problems occurred when they had infusions for more than 4 hours, when the cannulas weren't patent, and if you're worried, put the adrenaline down your IO intraosseous needle. Okay, so Mark, thank you very much. It was really fun coming up to Alnmouth and talking about what's changed in 2020 and what has not. So we've been talking about the new Surviving Sepsis Campaign International Guidelines for the management of septic shock and sepsis-associated organ dysfunction in children. It's kind of reminded me what's important. It's important to have a system. It's important to screen. It's important to still think about lactate occasionally, antibiotics, get them in as soon as you can, but you have got a bit of time if you have a febrile child, not a shocked child. Fluid, guess what? It's not that different. Give small boluses, reassess, look for fluid overload, think about cardiac output and who can help you assess this, get help, ring people. Inotropes, use adrenaline, use it peripherally, and you will save lives. Any other important suggestions or recommendations you want to share? This is your chance to get all your pet hates, likes, dislikes on air.
Guidelines like this don't allow us to have pet hates. It's the only consensus from a committee and from evidence. I think the guidelines take a very neutral position on steroid treatment in shock. And that genuinely reflects the evidence. But in truth, we just don't know the answer now.
Like so many things in medicine, we just don't know the answer. But fortunately, we have people who we can ring and ask, like you, Mark.
Yeah, well, I'm not sure I know the answer to that, but I know what my practice is.
Excellent. Okay, so that takes us to the end of this episode. From the Northumbrian coastline, it's goodbye from me and goodbye from him.
No, goodbye.
This podcast was created by MediSense. You can find more podcasts and other creative learning resources on our website at www.medisense.org.uk.